And welcome back to Health Watch. We've been talking to Dr. Ray Jagan about some of the degenerative and other arthritic symptoms of the wrist. And again, just to get back, a repeat would be let's take a look at the wrist and the different bones that are involved in this.
Okay. This is a model of the wrist. The anatomy of the wrist is quite complex. It's made up of 15 bones and at least 25 ligaments. The radius and the ulna, or the forearm bones. There are 8 small carpal bones, and then the 5 metacarpals. These are all held together by a variety of ligaments which allow very complex motions in nearly every direction. And all of these small bones, all these surfaces are covered with articular cartilage. That's the smooth, white, shiny material that basically allows smooth, comfortable motion. What I'd like to start with are some of the arthritis conditions that begin on this side of the wrist and will progress over to here. One of the more common ones that we see is called basilar joint arthritis. On your hand, it's located right down here at the base of the thumb. We see the first metacarpal articulating with a bone called the trapezium, and oftentimes the cartilage will wear out at a fairly young age in some patients there. We'll start seeing symptoms frequently in 40-year-olds. Again, this is one of the areas where I a little more commonly see it in women, probably twice as often, often due to some ligamentous instability, which allows abnormal motion at that joint, causing it to wear out prematurely. Almost all of these degenerative conditions are initially treated with simple things like anti-inflammatory medications, bracing, maybe an occasional cortisone injection, decreased activity. But once it gets beyond the point where those things work, we can do surgery. There have been a variety of surgeries designed for that type of arthritis. One of the original procedures was to do a fusion, where we would basically make the first metacarpal and the trapezium joined together as one bone, so there would be no motion, but it would eliminate pain. As you mentioned, though, we'd like to preserve function if
sure.
possible. So after that procedure, we moved on to actually resecting this entire bone, take the trapezium out, and then we would take a tendon from the forearm, basically roll it up in a ball, place it in there as a spacer, and that would allow motion, but the thumb shortened. It resulted in significant weakness of pinch strength. Subsequently, we developed a procedure where we would take the bone out, but instead of just taking a loose tendon and putting it in there, we would take a portion of tendon and create a new ligament. Basically stabilize this metacarpal so that it didn't shorten so much, and it allowed much better pinch strength and still good function. That's an operation that we still do a lot of. It's very good. I think the results are excellent. In order to maybe remove less bone, there's a procedure that we'll do where we just take a thin wafer off the end of the trapezium bone, and we have a small piece of material. These flaps fold down. It looks like a T, and then we slide it right into that joint there and suture it down. We close soft tissue over top of that, and a fibrocartilage type of material grows into this woven mesh, and then produces a natural cushion in between the bones, which then still allows motion with only minimal resection of bone.
Now that's not absorbable, right?
It is actually slowly absorbable,
Okay.
but it takes about 7 years or so.
But by that time, the cartilage is built up around it.
Right, right. So this was designed in Sweden. They did some long-term studies and had very good 10-year results. It's been here for several years, and we've been using it for a while, and I think with very good results. I do find that the patients get their strength back faster. They seem to function a lot better, and The only problem is it's a very expensive piece of material, so we are a little
What
selective.
isn't anywhere?
All right.
Is that your primary recommendation at this time?
My two favorite procedures there are to resect the trapezium if it's a very advanced arthritis and do a ligament reconstruction,
Okay.
or if it's a milder arthritis, then we can take that out. Now, sometimes the joint just requires stabilization. You don't have to take any bone out. It might just be too loose, and you can tighten it up. That can be done with an open procedure and even an arthroscopic technique. There is also an arthroscopic technique where we can go in and just shave out some of the arthritic bone, and that's a much quicker recovery.
Can you make that judgment before surgery, or do
we
you
try to make that ahead of time?
And how do you do that?
Based on X-rays, the age of the patient, and
so you have a pretty good plan prior to going in. It isn't as
usually have a definite plan.
Okay.
Sometimes there's a couple different options that we'll keep in mind. The next joint down, called the STT joint, also can become arthritic. Sometimes that's combined with arthritis at the joint we just talked about. But many times it's isolated, and treatment there, again, the traditional treatment is to fuse all three of those bones together. The downside of that is that it eliminates what we call the dart throwing movement. It definitely works as far as relieving pain, but a lot of laborers require that dart throwing movement for their occupation, and that can become problematic then. So another option is just to actually arthroscopically go in and trim out several millimeters of bone, leaving a space in between, and oftentimes that can provide normal motion and pain relief.
Yeah, I'm still amazed at the availability of arthroscopes for these types of joints, which we wouldn't traditionally have thought about.
Well, as you can see, that's a tight space. So getting an
amazed
arthroscope in there and a little burr, like a little
yeah.
Dremel tool, it's a tight squeeze. But with some traction on the hand, that it can be done. Moving the next joint over here, the scaphoid. This is the scaphoid. This is the lunate bone, and we can often see ligamentous injuries between those two bones. That can cause a huge problem to the wrist, which ultimately results in degenerative arthritis. It's a problem because it's often difficult to diagnose that when the injury is fresh. So a lot of times these patients have gone for years, and then they come in and they have severe arthritis between the scaphoid and the radius. Another condition that can cause that same thing is a fracture of the scaphoid, which never healed. So as far as options of treatment there, one operation is called a proximal row carpectomy. There are two rows of bones. This is the proximal row, this is the distal row. And what we can do is actually remove that entire row of three bones, and then the next row, and this bone particularly called the capitate, can move down into the radius and articulate similar to what the previous bones did. Now, because there aren't as many bones, there's not as much motion, so you tend to lose approximately,
yeah, you think you will.
approximately 50% motion, but that's actually very functional. You really don't need all of the flexion extension to do most activities. So that's a very good operation. One of the conditions that is necessary for that to be successful is that the cartilage on the capitate has to be healthy. If you have arthritis there, then that might not be a good option. There is some research being done on cartilage transfers for the carpal bones, and there is a fairly new procedure where we can take cartilage from one of the healthy areas in the wrist and transfer it to the end of the capitate, so that you can still do a proximal row carpectomy and have reasonable cartilage, even if it wasn't arthritic.
Okay. We're going to take a break again. We're going to continue on our journey here through the wrist and some of the other surgical procedures you can do. We'll be right back after this message.